dear colleagues. Today we have a very wonderful meeting, and Professor Adel Rifat, the head of the department, has named this meeting Meet the Spine Giants. Actually, we have a meeting today with 4 spinal surgeons that they are related and they are attached to Alexandria Spine Surgery Unit, but they are now, 3 of them are now working in Germany. I would have the pleasure to introduce the first speaker, the Dr. Mohamed El Hashash, and he is now working in Germany since so many years, and he is going to speak about minimally invasive spinal surgery. The time allowed is 25 minutes. Then I would greatly introduce him to start his talk, and at the same time, please stuck to the time allowed. Okay, Hashash, please.
Okay. Assalamu alaikum and hello, everybody. I would like to thank Professor Adel Rifat for this wonderful plan and the kind invitation. Dr. Abdullah Hamad has also performed a great work to gather us together. And I'm happy to meet my professors and my brothers in our home in Al-Hadra University. I will discuss with you a very interesting topic. It is not an educational element, but it is an open discussion to show what is new in this expanding field of minimally invasive spine surgery. Primarily, the popularity of minimally invasive spine surgery has increased along with advancement in surgical techniques and technologies in recent decades. With its aim of minimizing surgical morbidity and achieving the same surgical outcomes as the traditional open surgeries. Minimally invasive spine surgery is advocated when possible to avoid excessive approach-related injuries and subsequently preservation of normal anatomy while allowing rapid recovery as well as better quality of life. In recent years, many studies have reported that patients treated with minimally invasive techniques experienced lower intraoperative and perioperative adverse outcomes, has shorter operative time, and a faster return to work. This is possible due to advancement in technologies, starting with high-quality X-ray devices, microscopy, endoscopy, navigation systems, robotic surgeries, neuromonitoring, and in the late time, telesurgery, which is based on teleradiography and high-speed internet connections. I will discuss some examples because this field is expanding and we can't talk too long time in one aspect, but I will try to summarize what we as a family from Al-Hadra and Spine Unit achieved and together with our work abroad. The first is in disc surgery and spinal canal stenosis. It is the most common problem that faces us daily. Disc prolapse, spinal canal stenosis. There are 2 parallel techniques, microscopic techniques and endoscopic techniques. Our family from Al-Hadra and from Germany adopted the first microscopic technique because of many reasons. Microscope is available in nearly all operating theaters. Three-dimensional evaluation intraoperative is easier, and the equipment are simpler than endoscopic technique. Endoscopy is a valid way and a good way, but our experience is mainly for microscopic surgery. It started with lumbar spine and expanded to include cervical, thoracic, anterior cervical, posterior cervical. The story begins in the 19th and at the beginning of 2000s, where Professor Alam, Professor Saghier, Dr. Granabers, and Professor Boom they have together the tubular system introduced. This tubular system is a solution waiting for problems because it allows us through a small incision to reach places which is difficult to reach through a small incision without this tubular system. Using high quality X-rays to localize the anatomy, and through this tubular system we reach, it started with normal interspinous disc, and it is evolved to reach cranially migrated disc through a transosseous approach, foraminal disc. Nearly in all pathologies now we can reach the disc through this small incision with this tubular system. We advanced this technique to include fresh and new discs, even in anterior approach in cervical spine. In combination with other techniques, we achieved many goals, starting with small discs, now with recurrent discs. Dr. Yasser Alam and Professor Saghier performed very good work to compare the different techniques, and it is, from my own opinion, a standard technique now to reach the spinal canal stenosis and the disc problems without the need to open or to perform a bigger incision. The second application of minimally invasive technique is percutaneous fixation. Percutaneous fixation is also expanding, and at the start, when we started the first cases in 2005 and 2006, it was difficult to find which patient to be suitable for this technique, because in many situations we need to make decompression, for example, in cases of spinal instability. But with advancement of the technology and now there is a very wide application of percutaneous fixation. We started with cranial problems like atlantoaxial instability. Professor Hesham Saghier in early 2004 had introduced a very genius approach to put the C1, C2 screw through a minimally invasive approach combined with fusion through a small incision. It is less invasive than the classic magar fusion. We developed a more advanced way in patients with multimorbid conditions who are not suitable for long surgeries or are old and have many associated problems. We introduced the idea of percutaneous screw fixation without fusion in old patients, and it is now for last years a valid method to stabilize C1, C2 joint without the need of open surgery in patients who cannot tolerate this type of surgery. It needs two high-quality X-rays and a very simple instruments which are normally used for open techniques. In the thoracic and lumbar region, the indication of percutaneous fixation is expanding either alone or in combination with minimally invasive anterior column reconstruction or fusion. In the last time, it is for deformity surgery a good option to perform the stabilization through minimally invasive approach, and through a small incision we can perform the osteotomy. This spares too much tissue dissection and bleeding. The problem in minimally invasive screw insertion is radiation exposure. I tell my junior doctors always, don't let the others push the button for you. We can spare too much radiation when we put many screws in the same time to use one X-ray for 4 or 5 screws at the same time. With experience, we can reduce significantly the amount of radiation exposure. It is a very interesting work. Dr. Yasser Alam introduced. We will discuss this problem later on, that navigation system can significantly reduce radiation exposure, but it is expensive. In our country, in Egypt, for example, it is easier to find 2 X-rays than to buy a very sophisticated navigation system. But it is a very important issue to take care about. Radiation exposure for surgeons is very important element, and we need to learn the young colleagues that they must use the exposure wisely. The third application of minimal invasive technique is infusion surgeries. It starts with graft. We can use minimal invasive graft harvesting, especially for cervical fusion. In our old school, we use always autologous bone graft. In many cases, we can use locally harvested graft, but in situation when we need bone graft, it can be through a minimal invasive approach, anterior or posterior iliac crest. Lumbar fusions, the classic fusions are now gradually replaced with minimal invasive techniques using microscope, retractors, percutaneous screws. Interesting field is also the retroperitoneal approach through a minimal invasive approaches and the thoracoscope. This is will be discussed in the second talk from Dr. Shosha. Like nearly everything we learned, Professor Saghier started the story of extraperitoneal, extrapleural approach in the thoracolumbar junction, where we have difficulty through endoscope to reach the lower thoracic region or upper lumbar region, and at the same time in the upper lumbar region through a classic retroperitoneal approach. Sometimes it's difficult because of the lower ribs. Professor Saghier in 2002 introduced his approach through resection of the lower rib. So we reach the retroperitoneal space, and we are extrapleural. We can reach the last thoracic vertebra and the upper 1 or 2 lumbar vertebra through this approach without extensive dissection. The new technique, it is meanwhile not new, about 25 years, the endoscope, and this will be discussed in details in the second talk from Professor Shosha. The third application of minimal invasive techniques is cement augmentation. Spine started later than other parts of the body to use cement after knee and hip, but we are very rapid expanding. We use bone cement nearly in all applications. The population is aging in our country also, so osteoporosis. It is started with vertebroplasty, kyphoplasty, with its modification. Now screw augmentation with cement to increase the purchase of screws. Injection of bone cement in discs in degenerated conditions and in pseudoarthrosis in selected patients is evolving. It is a way to fill the space and to reach adequate stability without the need to open and make extensive surgeries. We take part in this development with comparative of different cement types. Dr. Tarek El-Fay, a very good and big baler in the spine unit in Alexandria, with many participation in science in different continents. One of his work is to use lavage to minimize the main risk of cement augmentation, which is cement embolization. The problem is not easy to inject cement. The big surgeons have more respect and more fear from cement injection. We studied a big number of patients, and in some patients we have to remove cement from the right atrium or from the left ventricle. It is not simple. We must take care, and 2 X-rays are needed, and high quality X-rays. And when you have suspicion that bone cement is not in the place where it is normally to be, it is better to stop. The fifth element to discuss today with you is deformity surgery. Deformity is the top of the spine surgery. When we speak about minimal invasive deformity correction, it is the use of microscope, endoscope, minimal invasive decompressions, minimal invasive screw insertion. The aim is to minimize injury, but we should not accept under correction or a bad result in cost of to make a small incision or to avoid big incision. Dr. Saghier was Professor Bem. They started the story from the start, and they tried to minimize the need of the classic correction of scoliosis using endoscope. It has advantage to shorten the fusion because we can through 360 degrees release, derotate the spine, and we can minimize the need of extension. It is debatable if this for every case to be used, but it is an advantage, especially in severe cases or rigid cases. We can go anteriorly through a minimal invasive to facilitate correction. In prone position, this debate of if prone position better than lateral decubitus, but learning curve in prone position is long. When you master the technique, it is an easy thing to stay in prone position to avoid the repositioning of the patient, spare time, and you can change from posterior to anterior. This will be discussed from Dr. Shosha in the second talk. In the last few years, there is advances in many techniques, robotic surgeries, navigation system like O-arm, telesurgery even is now in experiments, especially from China, where the 5G and Huawei firma. Professor Alam is one of the pioneers of O-arm. He worked in 2 big hospitals with 2 O-arm, and published interesting papers about accuracy of screw insertion, freehand and O-arm. In lumbar spine, in experienced hand, there were no big difference, but in thoracic spine, there is a significant difference where it is also dangerous in the thoracic spine. And these 2 studies, I recommend the doctors to read these 2 studies. There is no limits. We can every day see and participate in new techniques. For example, development of posterior percutaneous, cervical, pedicular screw insertions. It is about techniques and technology. Even in the pandemic situation where the communication is more difficult, the need to facilitate communication between hospitals and even to perform surgeries, the surgeon is in his office and the robotic arm can safely perform simple operations. There is no limits, and I summarized my experience in this field in this recommendation. The first recommendation is it is, when possible, master the open method first. Because, for example, in thoracic spine, I know many young people who can perform percutaneous screw fixation, but they cannot put open thoracic spine screws. I will recommend to start with open screws in thoracic region. But in some situation like disc surgery, I don't think that there is a place for conventional open surgery for this nowadays in development of microscope and endoscope. Exact anatomical landmark is very important. A very big example is Professor Saghier. When I was young and I started to work with Professor Saghier, I thought that I can put everything correct without seeing it, but it is not the reality. He sees what we don't see. So don't try to start something that you don't see before and perform. So the anatomy is very important, and it is better to make a bigger incision to be sure than to put something and later on it is not what you thought to be. There is sometimes this hysterical thinking that I will perform everything through a small incision. We tried something for about 5-6 years. We tried to perform 4, 5, 6 level percutaneous decompression in all patients with percutaneous screws and malleable rods. It was fine in 2, 3 levels, but 4 level, 5 level, it is very difficult because of time consumption and we will grow old and we have back problem. So I will limit the indication to the reality. Too much minimal invasive is not always good. The preoperative planning is very important. Coronal MRI, foraminal views, dynamic views, we should start before the operation. A very good example is in the transosseous lumbar spine disc removal. When you make your hole exactly where the disc is, it is a very simple problem. But when you make a bare hole away from the anatomical landmark, so you can cause more damage than open approach. It is not about a small wound. Through a small wound, we can injure vessels, we can injure the lung, we can injure the spinal cord, cement embolus in heart or lung. It is about a technique to be safe and not to be small. So the term less invasive is also important. For example, stand-alone cage in cervical spine, it is a classic surgery, but I think it is a less invasive than plate or posterior fixation. So we should weigh the advantage and the limits of them. We stand on the shoulders of the giants. We cannot start from scratch without Professor Saghier and Dr. Alam. We couldn't perform too many operations. So I will advise everybody to attach to an expert and to grow barrel to him. And when you are able to perform these things, so you can go and do your techniques. But in the beginning, I would recommend stick to the rules, have a mentor, and follow him. The last question is minimal invasive a standard method? I think in some pathologies, yes, like disc surgery or like simple fusion in thoracic spine, so an endoscope. I think it will be correct to say this is the standard way to perform these surgeries. The concept of less invasive, we can start with better dissection, better hemostasis, proper soft tissue handle. It is by every surgical step important to think, can I do it with a less tissue injury, so it is minimal invasive. Thank you very much, and I hope that was not too long or too diverse. And I thank again my brothers and my professor.
Thank you very much, Professor Hashash. It was an excellent lecture. It has given some spotlights on very nice aspects in the minimal invasive surgery. Actually, we have to all the people working in the spine, they know that minimal invasive doesn't only mean small incisions. Sometimes you make a small incision and through this small incision, you can do a huge tissue damage. Then it will be better to make it a little bit longer to decrease increase the damage to the tissues if you are not able to do it through these small holes. It means, doesn't mean a small incision, it means better or small damage to the tissues. If you achieve this through the small holes, it will be fine. If you not, then better increase the incision a little bit to do the job with minimal tissue damage. But it was very interesting lecture. Thank you very much, Professor Al-Hashash. Now we have to shift to the giant of Central Clinic Bad Berka, the head of the Department of the Spine Surgery that we are all proud of, Professor Moataz Shosha, and he is leading one of the biggest centers in Germany since now 2 years, nearly 2 years or more than, a little bit more than 2 years. Moataz, he is one of the most decent and most clever spine surgeons. We are proud to have him in El Hadra as one of our units. He is now responsible for learning a lot of the young colleagues traveling to him. And now he has, for example, Hesham and Shams Singabi, Mustafa Hassab. Then we wish all the time to have him in our unit, but he is doing a better job there. Moataz is going to give us a lecture about the rule of thoracoscopy in spine surgery. Time allowed is also 25 minutes. Please, Professor Shosha, you can start.
Thank you very much, Dr. Yasser, for this nice introduction and these nice words. This is too much for me. I am your student and the student of all my mentors in Alexandria. I think there is a problem with screen. Dr. Hashash must
go لازم تلغي السكرين بتاعتك يا حشاش.
اوكي.
يعني يعمل ايه عاطف؟ عاطف مشي وسابنا بيه.
لا انا موجود يا بيه. انا موجود يا بيه. يعمل ستوب سكرين شيرنج بعد اذن حضرتك.
يلا
علينا
دكتور محمد يا ريت تعمل ستوب سكرين شيرنج يعني.
انا بدور عليه ام سيرشنج
في نفس المكان اللي حضرتك عملت منه ستارت سكرين شيرنج.
بس كده خلاص.
اوكي.
Fine.
Okay, you can see the بين المحاضرة ولا ايه؟
Everything is clear, Professor Shosha. Everything's fine.
I can proceed. Okay. Yeah. Dear Dr. Adel Rifat, dear Dr. Yasser, dear big family in Alexandria, it is an honor for me today to speak about thoracoscopy in this wonderful webinar. We are sitting here in Germany, in the middle of Germany, but our hearts are in Alexandria. I am speaking today about thoracoscopy in spine surgery. As we all know, the endoscopic techniques have substantially affected almost every sphere of medicine and surgery. Stop. And the advantage of endoscopes is that they provide illumination, visualization, magnification, and a conduit to access almost every region of the human body through very small skin incisions. Let's start with a historical overview. How did it start? It started in Germany, 1806, by a physician called Bosini in Frankfurt. He developed an instrument called Lichtleiter or light conductor. It consisted of a candle attached to a thin cannula in order to illuminate the cavities. It had no magnification, no optics, and was inserted in the rectum, urethra, or vagina and the physician looked through the device. 1887, also a German urologist called Nietzsche introduced several modifications, and the cystoscope was improved by adding a small light bulb at the distal end, allowing better visualization. And it consisted of a working channel, a light source, and an optical lens through which light was reflected. In the early 90s, the endoscope was being used for diagnostic and therapeutic purposes in the pelvis, abdominal cavity, and later the thorax. Kelling from Germany again developed these techniques, and he performed the first laparoscopic surgery in dogs, 1902. And he refined these techniques and published his report on laparoscopic surgery in humans 14 years later. 1929, he developed flexible endoscopes, which led to further improvement of these techniques. 1910, Jacobius from Stockholm, after learning the techniques from Kelling in Germany, introduced the technique of thoracoscopy, the first time to use this thoracoscopy. He was an internist. In the early 90s, the spinal thoracoscopic techniques were independently developed by Regan in the United States and Rosenthal in Germany. They were the first to publish about thoracoscopy in the spine, and they introduced the term WATS, or video-assisted thoracoscopic surgery. 1997, Heinrich Böhm and El Saghier introduced a modification to this thoracoscopic technique in the spine surgery and accomplished the procedure in the prone position as a biportal WATS. And this is the new technique introduced, and I have the honor to get both of them as mentors for me. But thoracoscopy is just a way to access the anterior column of the thoracic spine. The standard open approaches to the anterior column are either by anterolateral thoracotomy or posterolateral costotransversectomy. A costotransversectomy offers an extrapleural approach for the spine with no need for postoperative chest tube application. It does not allow a good visualization of the anterior pathology when compared to the anterolateral approach. The anterolateral thoracotomy approach has been described in 1956 by Hodgson and Zock for the treatment of Pott's disease originally. Though the exposure is excellent, the morbidity, including post-thoracotomy pain and associated respiratory problems, is significant. And the new model of this anterolateral thoracotomy is actually the WATS. It is just a new model of the same technique. What are the advantages of this new model? It offers a better visualization. The surgeon and the assistant, both of them, can see the same picture. It offers a better skin incision, a smaller one. It offers a better illumination and a better magnification. Again, it offers less pain postoperatively, less morbidity, less infection, and less hospital stay. However, this technique has limitations. The learning curve is steep. How to make it easy? There are two ways to make it easy. We can use 3-dimensional monitors to offer better depth perception, and to use this modified technique of biportal instead of multiportal WATS. What is multiportal and what is biportal WATS, or the thoracoscopy? Multiportal, usually the patient is lying on the lateral position, and multiple skin incisions are used, and the surgeons are standing. The biportal, usually in the prone position, 2 skin incisions, one for the working instruments and one for the optic, and the surgeon is sitting. Which is better? Each technique has advantages and disadvantages. In multiportal WATS, it has the advantage that more levels could be reached due to a better adaptation of the incision, especially in deformity surgery. This is a disadvantage in the biportal technique because you can reach only the convex side of the apex. The multiportal WATS, bulky implants could not be inserted without elongation of the incision. This is a manco in this technique. In the biportal technique, you can insert huge cages through this mini thoracotomy approach. The multiportal is usually done in the lateral position, so you can convert to open surgery. This conversion is easier, but the biportal technique, the prone position is possible, and it has also advantages. No repositioning of the patient is necessary, it saves time, better intraoperative orientation, better reduction of kyphosis when needed, great vessels fall down forward, blood and debris fall anteriorly away from the spine, and double lung ventilation is possible, and the surgeon is sitting. As a summary, thoracoscopy requires several new skills, psychomotor strategies, and perceptions of the anatomy that differ substantially from open surgery. However, surgical techniques and instrumentation have improved so that the same surgical procedures can nowadays be performed by the thoracoscopic approach as previously accomplished by the open techniques, including spinal decompression, anterior column reconstruction, and anterior instrumentation. And the whole spectrum of spinal pathologies necessitating a ventral surgery between T1-2 till lumbar 1-2 could be addressed with assistance of the thoracoscope. Let's go into some details with some practical tips from the surgery. The first category is degenerative disc disease, and thoracoscopic discectomy is an elegant, minimally invasive way to remove a herniated thoracic disc, as shown in this MRI. The safest approach for exposing the dura involves removing the head of the rib during the thoracoscopy and sometimes a portion of the pedicle rather than dissecting through the neural foramen. An early identification of the dura allows the surgeon to visualize the border of the spinal canal. As we all know, we du connu vers l'inconnu, that's to say, from the known to the unknown. You should expose the dura at a normal structure, and from that normal structure, go to the pathological structure. In deformity, scoliosis, we can use thoracoscopy for anterior release, and the spine is usually approached from the convex side. It is easier, and caution should be taken because the vertebral bodies are rotated, which could make the orientation difficult, putting the spinal cord in danger. The second use is restoration of the thoracic kyphosis, because one of the main advantages of anterior release is the ability to shorten the anterior column by performing multiple discectomies. Another use is the anterior instrumentation and fusion, can also be performed thoracoscopically, or vertebral body tethering, as first introduced by Lenki in 2010, can nowadays be performed thoracoscopically also. And thoracoplasty can also be performed using the thoracoscope, and the portals are established across from the apex of the rib hump to provide proper access to the ribs that need to be addressed. This is an example of a 14-year-old male patient. He has been treated conservatively with a brace over a period of 4 years and presented to us with this picture, and we performed posterior correction together with thoracoscopic anterior release to get restoration of kyphosis and to correct the deformity. A second example in the deformities is not only scoliosis, but Scheuermann kyphosis, and the anterior thoracoscopic release permits better curve correction, saves fusion segments, and avoids loss of correction that can occur in posterior only surgery. And technically, the incisions, or the incision for the thoracoscopy is done more posteriorly than the standard ones in order to get access to the kyphotic spine, displaced dorsal. Third point in deformities, ankylosing spondylitis It helps in completing circumferential osteotomy in the thoracic spine or the thoracolumbar region. Because an anterior wedge osteotomy, the Spies-Patterson osteotomy, we can offer with the thoracoscope a controlled gentle breakage of the anterior column in order to get opening or open wedge of the anterior column. Furthermore, the thoracoscopic technique allows addressing Anderson lesions from the front. This is an example of an advanced Anderson lesion in ankylosing spondylitis with kyphosis and was corrected thoracoscopically and with posterior fixation percutaneously. And these are the skin incisions for the percutaneous screws as well as for the thoracoscope. This is another example of ankylosing spondylitis patient treated minimally invasive through posterior percutaneous fixation and anterior thoracoscopic release. And a third example of global hyperkyphosis in ankylosing spondylitis. He was treated with posterior percutaneous fixation, percutaneous osteotomy, and anterior endoscopic or thoracoscopic open wedge osteotomy. And another use in deformities and angular kyphosis due to bone necrosis, for example, or following discitis, and it's used to re-lengthen the anterior column. The prone position in these cases is very beneficial to achieve this goal, as it permits simultaneous posterior surgery and get benefit of the gravity forces during the correction procedure. And this is an example of a 66-year-old female patient with necrosis as T11 and T12, presenting with angular kyphosis, and was treated with percutaneous instrumentation. The screws were augmented with bone cement, and the anterior column was reconstructed with corpectomy of T11 and T12 and cage substitution using the thoracoscopic technique. The third use is fractures, and thoracoscopy in these cases allow gaining the advantages of anterior decompression and reconstruction of the anterior column, as in open thoracotomy with less approach-related morbidity, and the posterior column remains preserved, untouched, and this offers more stability when comparing it to the costotransversectomy or laminectomy approach. Care should be taken in these cases to prevent or to preserve the nutrient vessels of the anterior fourth of the vertebral body, and we push this part en bloc anteriorly during insertion of the cage, and then will be repositioned next to the cage like a vascularized flap. As seen in this example, this is an A4 fracture of T12 in a 40-year-old male patient, and we left this anterior broken part as a vascularized flap, and the cage was inserted thoracoscopically, and a posterior percutaneous instrumentation was performed. Also in osteoporotic patients, this is a 68-year-old female patient with osteoporotic fracture and angular kyphosis. This was corrected by corpectomy thoracoscopically and posterior percutaneous instrumentation with bone cement augmentation. The fourth example is in the spondylodiscitis. Thoracoscopic anterior spinal surgery is proved to be of great benefit in spondylodiscitis. In order to get benefit of this minimally invasive character of the procedure in this labile multimorbid group of patients, it allows anterior debridement of the necrotic tissues, drainage of epidural abscess when present, together with reconstruction of the resulting defect and fusion. Two aspects should be considered in this type of pathology. First, the lung is usually adherent to the affected disc space and the prevertebral pleura. Care should be taken while mobilizing the lung from the vertebral column to avoid its injury. This can be accomplished by blunt dissection using surgical sponges. And second, the chest tube applied at the end of the procedure is left for a longer time to avoid pus recollection in the thoracic cavity. This is an example of a spondylodiscitis treated thoracoscopically with debridement and fusion and posterior percutaneous instrumentation, and it shows a solid fusion could be achieved. And these were the intraoperative pictures with percutaneous screws and thoracoscopy done biportal thoracoscopy. The last item is the spinal tumors, and the prerequisite to apply this minimally invasive technique in tumor resection is the localization of the tumor in the vertebral body without a posterolateral extension towards the dorsum of the spinal canal or the posterior column of the spinal cord of the spine, in which condition a costotransversectomy approach is preferred. Here's an example. Suffering a 60-year-old male patient with prostate metastasis, T12 and L1, and was treated with anterior corpectomy of both vertebral bodies, thoracoscopic cage, reconstruction, and posterior stabilization with bone cement. But what are the complications and the limitations of this technique? First, post-operative intercostal neuralgia, but the incidence of such a complication is much less than after open thoracotomy. Wound infection would occur, but is extremely rare. Post-operative pleural effusion, persistent, can occur and might necessitate reapplication of a chest tube. Post-operative hemothorax could also occur in case of post-operative bleeding, as in any surgery. In such cases, post-operative CT and reoperation might be necessary. Post-operative pneumothorax, if occult leakage from the lung occurred during surgery without application. In such a case, we must communicate with the anesthetist and ask him if there is leakage from the lung. And if this is the situation, we insert a second chest tube ventral to the lung in order to avoid post-operative pneumothorax. Another important point, when a sudden deterioration in the general condition of the patient occurs during surgery, you should always think about pneumothorax of the contralateral side, because sometimes you can reach the other side with your instruments, and in such a condition, a pneumothorax on the other side occurs. And this is an advantage in the prone position so that you can introduce a chest tube directly on the other side. But these all are rare complications. Subcutaneous emphysema is also a rare complication that can occur if the chest tube is inadequate. And respiratory function deterioration could occur in multimorbid patients, and or major pulmonary or vascular injury or injury to the diaphragm or spleen have also been reported. And in such conditions, you should convert to open surgery. What are contraindications? Coagulopathy or inability to tolerate single lung ventilation or small tidal volumes in case of double lung ventilation, irrecoverable terminal illness, severe cardiac or pulmonary disease, extensive pleural adhesions from prior thoracotomy. This is a very important point. And when thoracotomy is infeasible, other operative alternatives include thoracotomy or costotransversectomy, depending on the level and on the pathology. What are our take-home messages? Thoracoscopic spinal surgery is a safe, minimally invasive technique that can replace open thoracotomy in most of the cases. It allows access to the spinal levels from T12 till L12 with even better visualization due to better illumination and magnification. The technique can be applied for all types of pathologies involving the anterior column of the thoracic and the upper lumbar spine, including deformity surgery. It has the advantage of decreased pain together with a shorter hospitalization and rehabilitation period. The learning curve is quite steep. However, the modern 3D cameras allow better orientation, enhancing a flat learning curve. Multiportal WATS allows more levels to be released in scoliotic patient spine. However, biportal WATS is possible in the prone position and allows easy insertion of implants. And my last message, thoracoscopy or WATS is just an approach. No compromise in the original aim of surgery should be accepted. Thank you very much.
Thank you very much, Professor Shosha, for this nicely illustrating lecture. All the time when I want to give an example or make the idea of the endoscopy for the students more clear, I tell them that endoscopy is to build a ship inside a bottle of glass. Sometimes we see all the bottle of glasses and inside them a big ship built inside. And this is what we mean by endoscopy. Moataz, Professor Shosha has a very long experience with this endoscopy till now, and he is one of the, I think, one of the most trained personnel in doing such type of surgery in the prone position. Thank you, Professor Shosha, for this lecture.
Thank you, Professor. I am your student, student for Dr. Saghier.
متواضع زي الدكتور الشاجير بالظبط. هو علمنا كلنا التواضع الحمد لله. Okay, should I give now the microphone to Professor Adel Rifat to introduce the company talk?
I'm not sure. Is the company ready for a lecture or not? I think Isra Muhammad Atif was us.
موجود مع حضرتك.
Is Isra is ready for a lecture or no? They told me they don't want to give a lecture.
هم ما قالوليش ان هم عايزين يقدموا محاضرة حضرتك.
Yes, they don't want us.
احنا ممكن حتى يعني نكمل ولو هم كده ممكن يبقوا في الآخر مفيش مشاكل.
Okay, so Professor Saghier, Dr. Alam will proceed, I think.
Okay, now we are going to have a lecture from the giant of the giants,
Yes.
Professor Hesham Saghier. مفيش حد يعني no one of us, every one of us knows Professor Saghier, that he is one of the best surgeons in the whole Egypt, and I am very grateful to him, and it is a pleasure for me to introduce him, to give his lecture. Very interesting topic and very interesting title as usual from Professor Saghier. All the time his titles are very unique. He is going to speak about stretching the spine of gymnasts, borders between safety and injury.
Thank you,
Professor Saghier, you can proceed, sir.
Thank you, Professor Adel, for this introduction. Thanks, Professor Adel, for pushing the department in the correct track, scientific meetings and publishing. Well, we see a lot of gymnastic injuries in Egypt more than in Europe. And actually, as I was in Germany, I thought the reverse. Well, there are several types of gymnastics. All have three criteria. They need flexibility, conditioning, and complete body recruitment. Well, the question, from where does the increased range of movement come? This is a very important question because flexibility is crucial for performance. Maximum stretching of ligaments, maximum stretching of joint capsules, maximum stretching of muscles, but also cartilage compression and deformation, fracture of the pars interarticularis at the lumbosacral junction, mostly L5, and deformation of bone. And actually, this is three last factors are red flags. Well, in any sport, there is a very important question: performance and safety, and there must be a balance for both to make this sport accepted from the point of safety. Well, gymnasts must consistently prepare for the rigorous physical activity and emotional toils that the sport requires, and this especially in high-level gymnastics, like Olympic gymnastics. And we see in this video severe flexion of the spine, severe extension of the spine, overstressing the thoracolumbar spine and the lumbosacral spine. And when you look in the literature, the incidence of spondylolysis in normal population is about 5%. In gymnasts, from 11 to 40%. And this means that this type of sport is injurious to the spine. Well, from where these injuries come? From overtraining, that means overuse, procedure-related injury from overstretching, overcompressing, repetitive stresses, asymmetric loading, and of course also acute injuries. And some of these injuries are serious, like power gymnastics. Well, what is the safety limits for the young gymnast? Shoulder, hip, wrist, and of course the spine. Well, there are also late sequelae of this type of sport, like degenerative changes. This is X-rays of a lady, and she told us that she was gymnast for many years. Well, the spinal problems can be summarized in back pain, spondylolisthesis, end-plate changes at the thoracolumbar spine, what I call it gymnast's thoracolumbar spine, lumbosacral disc fractures, and degenerative changes of the disc and the facet joints. And it is very important of all this can cause back pain, but there is a category of gymnasts who come with back pain without findings in the plain X-ray, CT, and MRI. And for this, SPECT is very important. And here I remember late Professor Arafa and his experience in dealing with spondylolisthesis. Well, if a gymnast come with a back pain with recent spondylolisthesis or without finding in the imaging, he might have a beginning stress fracture. And this is very important to catch these patients, because here the problem is solvable and we can restore the normal anatomy again. But if they come with spondylolisthesis or with end-plate changes, most of the, or with lumbar disc prolapse, or all these are treatable but not repairable. Repairable means that you can restore a normal motion segment. Well, this is an example of recent fatigue fracture, bilateral. And here there is a role for conservative treatment, and they can readily heal. The question is, can this gymnast return back to sport or not? The advice not to return back to sport, because he will develop again stress fracture. But when he comes with already spondylolisthesis, the question to continue his sport or not. And actually, I deal with these patients in a way, what is the effect of spondylolisthesis on the sport, not what is the effect on the sport on spondylolisthesis, because most of these type of spondylolisthesis do not progress more than grade 2. They don't progress more than grade 2, and if the gymnast can perform his activities with no pain, and the pain occurs after that, he can continue. He can continue, or he can shift to another type of sport. Well, this is the treatment of that patient 8 years, because in spite of having spondylolisthesis, they don't progress like other lytic spondylosis, because not all of them are dysplastic spondylosis. They have many of them have normal anatomy regarding the bone structure and the disc. The end plate changes at the thoracolumbar spine didn't receive attention like the spondylodiscitis, because many radiologists do not link the radiological finding to this type of sport. And the actual prevalence is not known, and some of the radiologists describe the changes as Scheuermann disease. Well, this is example of changes at the thoracolumbar spine with small nodule and deformation of the vertebral body. The MRI of the same patient and some degenerative changes at the L5S1 disc. This is another patient, and he was diagnosed as limbus vertebra. He's a gymnast, but actually it is also a sequel of the trauma affecting the anterior corners of D12 and L1 with thoracolumbar kyphosis. And this is the dynamic views. Another example, instability with also end plate defect at L1. MRI of the same patient and the dynamic views. Well, the changes occurring on the thoracolumbar spine are sometimes serious and need surgical intervention. Our spine is very stable, mobile. It performs its functions very, very excellent. It is well engineered, and it has a big reserve for both abnormalities in the structure and the functions. Why? It is not because of nature, because it has a creator. And when we look at the thoracolumbar junction here, we notice that the L5 always seated deeper than the iliac crest, and it is bound to the iliac crest with the iliolumbar ligaments. This allows gradual transition from a mobile spine to a stiff pelvis. This is very important. And I received this patient, gymnast, with low back pain during making bridge maneuver. And when you look at the X-ray, 5 lumbar vertebra, but here seems that there is a 6 vertebra, and the sacral slope is diminished. X-ray, 5 mobile, and the 6 lumbar vertebra is attached to the sacrum. This means that the 5th lumbar vertebra is not more deep, and the iliolumbar ligaments may be here replaced by bone. It means, and the number of the 12 vertebrae and 12 strip extra vertebra, but fixed to the spine, and this means acute transition from a mobile lumbar spine to the pelvis. This is not a normal anatomy. This is in association with a diminished sacral slope. And if we look at the MRI, the patient doesn't complain from the lumbosacral spine, but there are beginning also changes and tendency to kyphosis. And this is deviation from the normal anatomy, and the advice to this patient was to shift to another sport and not to stay with gymnastics. Well, there is narrow borders between safety and injury regarding the spine. This is very important. Every structure in the spine is very precious, and the concept is to protect these structures. Well, God give us a very, very mobile joints, which allows a movement and different postures, and also these postures are other postures are allowed, but we must think of safety. Prevention is very important. Yes, gear, we must require safety gear, health education, good selection of players, inspection of weapons, warm up, insist on spotters when learning new skills. A golden rule is don't play through pain. This is very important in sport. Don't play through pain. And lastly, and very important, that these kids are innocent. And sometimes I feel they are victims because of the desire of their parents. And honesty dictates that the parents must be informed about the harmful aspects of gymnastics. Thank you very much.
Thank you, Professor Hesham el Saghier, for this nice lecture. It's a very interesting topic, the spine of gymnastics. All of us, they meet such cases in the in the clinics. It was very illustrative, very nice topic, actually. Now we should shift to the last speaker in this webinar today, Professor Dr. Yasser el Mansi. عقبال ما يبقى professor إن شاء الله. Dr. Yasser el Mansi is leading the spine department in Aachen University, and he is going to join us at the beginning of December. We are actually very happy that he is going back home and to encourage and help to improve the unit. Among the speakers, among the audience, I should also give a lot of respect to Professor Rafat Kamal, Professor Fahmi Anwar, Professor Tariq El-Fiqi, Mahmoud Nafadi. They are also sharing us in this webinar today. Then I will allow Dr. Yasser el Mansi for his lecture about Enbloc corpectomy on thoracolumbar tumors. Very interesting topic. Please, El Mansi, you can start.
Thank you, Dr. Yasser. Thank you, Dr. Adil. Thank you all. I'm very pleased and humbled by the kind invitation. So, one moment, please. Now I have to share my screen.
Dr. Yasser?
Yeah, Aywa. You have my screen now? I'm sharing now.
دكتور ياسر حضرتك اعمل شير سكرين
كده وصلت؟
تمام دكتور ياسر.
So, okay, so I thought today I will be speaking about the Enbloc resection of thoracolumbar tumors. My name is Yasser el Mansi. So, regarding tumors of the spine, the etiology is, we know that primary tumors are very rare in the spine. The common ones are the chordomas or chondrosarcomas, osteoblastomas, giant cell tumors, maybe aneurysmal bone cysts, or if we count the multiple myeloma or plasma cell as primary tumor. The most tumors are metastases of the spine, and they usually come from the breast, lung, and prostate, and we know that at least 10% from all tumor patients are in the spine. If we talk about limb surgery, we all know the Enneking classification and the Enneking resection types. So the way Enneking described this, there were 4 types of resection. There was an intralesional resection with piecemeal debulking or curettage of the tumor, which is very well known for us in the field of spine surgery. There is the marginal resection with shelling out and blocks through pseudocapsule or reactive zone. And there is the wide resection with intercompartmental Enbloc with a cuff of normal tissue. And of course, there's a radical resection with safety margin and extracompartmental Enbloc with removal of the entire compartment. This is regarding the limb surgery. We can't apply these principles on the spine, as radical surgery with the removal of the safety margin is very morbid for the patients. We can't, if we see this tumor here, if we start removing the tumor with a cuff of surrounding tissues, we will end up incising the aorta and incising the spinal cord, which is something we can't afford. So we go to the next best thing, which is the Enbloc resection. Dr. Adel is here with us, and when we talk about tumors and Japan, then I think he knows this better than me. So this paper is from Professor Tomita in Japan, 1994. He was the father of the Enbloc spondylectomy. He described in 1994 his experience with 20 cases with spondylectomy, and he described his technique either to do a laminectomy using Enbloc, using something called Tomita saw, which is pretty similar to Gigli saw with different serrations of the cable. Or if going anteriorly and doing Enbloc spondylectomy, he will be removing a part of the ribs with the transverse processes and trying to go bluntly with the finger to separate the tissues from the anterior vertebral body and protecting the vessels. And at the end, going with his Tomita saw in the discs above and below, removing, cutting through the disc, and at the end, removing of the tumor. Tomita also described sort of classification in his paper, and he divided the tumors into intracompartmental, extracompartmental, or multiple lesions. Type 1 is affecting only one part, whether the vertebral body or pedicle or transverse process and lamina. Type 2 affecting 2, type 3 affecting the 3 parts, with type 4 extending to the spinal canal, and type 5 extending to the soft extracompartmental with more extracompartmental involvement, and type 6 and 7 are actually widespread, going to other vertebrae, whether with skip lesions or without skip lesions. According to his paper, type 6 and 7 are not suitable for Enbloc spondylectomy, type 5 only in some rare cases, and the other lesions can be treated with Enbloc spondylectomy. This is another classification, which is Weinstein-Boriani classification. It's actually not a classification, it is a way to nomenclate the tumors in order to describe the tumors to other surgeons, which part is affected, going from this area to this area, and whether it is extending extracompartmental or intradural. This will be given letters from A to F. The indication for Enbloc spondylectomy is basically in primary spine tumors, and in cases of single metastasis from a tumor, which with no other metastasis elsewhere in the body. And this all provided the patient has a good general condition in order to tolerate the morbidity of such an operation. In order to quantify this, Takahashi presented his classification or scoring system for the prognosis of the metastatic tumors, and this was based on the general condition of the patient, the number of extraspinal bone metastases, and the number of metastases in the vertebral body, and the metastasis to the major internal organs, primary site of the tumor, and whether there is a neurological deficit or not. According to his scoring system, posteriorly, with fixation and laminectomy, pediculectomy, and maybe release of the disc from posteriorly, and another stage, or maybe in the same surgery, the patient is either a thoracoscopy or a laparotomy is performed, and the vertebral body is removed in block. When we talk about such a surgery, the most important advice is to be well prepared, because this is a surgery where you can't afford to forget something or have some mistakes. Adequate radiological imaging is important. You have to have MRI and CT. You have to be sure that you are only treating either a single metastasis or a single solitary lesion. And you have to evaluate the extension of this tumor to the nearby structures, to the important vessels, to the spinal cord. Usually, we don't perform here any surgery, any elective surgery for tumor patients without having a tumor board decision. Every single case, which is not an emergency, should be presented in the tumor board, and only surgery can be performed after the decision of the tumor board. We have to work interdisciplinarily. If you perform a surgery and you go performing like an anterior approach with dissection of the aorta and the vena cava, which is for a spine surgeon, not the everyday work, you may go to such a surgery with another surgeon, with a vascular surgeon or a general surgeon, which is doing this every day. This will make your life easier and will make the surgery safer for the patient. If we are talking about a bloody tumor, like a renal cell tumor, you have to have the possibility of a preoperative embolization in order to reduce the risk of bleeding. And you have to have enough blood units for the patient. You have to have some measures to control the bleeding if it happens. And very important, especially when you are operating cervical or mainly thoracic tumor in the level of the cord, you have to have a neuromonitoring on board. This is another paper evaluating the results of a 10-year follow-up after total Enbloc spondylectomy, also from the group of Tomita in Japan. They reviewed 82 patients. Only 29 patients were found to survive after 10 years. Among the 29 patients, 19 patients had primary tumors, and only 10 patients with metastasis did survive that long. So actually, the biggest value of this Enbloc spondylectomy is with primary spinal tumors. This is another paper talking about the quality of life and complications after removal of a tumor, and they described three, and they compared three methods, whether Enbloc resection or debulking or palliative surgery, like simply fixation or cement augmentation or so. And they find that the survival rate was better in the cases of Enbloc resection, a bit lower in the cases of debulking, and of course, the palliative situations had much lower results because the patients usually were in a worse state of overall health. Regarding the complications, they found the complications were lowest for the debulking group, followed by the palliative group, 22%, and highest for the Enbloc group. So the morbidity of the operation is notably higher in the patients getting an Enbloc resection. On the other side, regarding only the surgical complications, they were higher in the palliative surgery group than the Enbloc or debulking groups, as these tended to have lower lower ASA scores. So the patients were less fit in the patients receiving palliative surgery. So I will be presenting some cases in order to illustrate. This is a 55-year female patient with platinum epithelial carcinoma, which presented to us from the surgical department, and he had an affection of the L3 vertebral body. The colleagues, they wanted to remove this tumor and wanted us to remove this vertebra Enbloc in a combined surgery. So we started first posteriorly, we performed a fixation, and then we performed a laminectomy in the level of the vertebrae. We performed an pediculectomy and transversectomy, and we did a discectomy of the discs above and below, extensive discectomy in order to facilitate the section. And in the same procedure, the surgeons wanted a double J caster, so this was inserted from the urologists. And then 1 week later, we performed another surgery. The surgeons went first. They made a transperitoneal approach and removed the extraosseous tumor and prepared the arteria, the aorta, and the vena cava. And then we performed a resection of the vertebral body after opening the disc and preparation of the vertebral body from the psoas muscle. And this is the vertebral body after removal. Another case, 66 years male patient, renal cell tumor with a single metastasis. Same procedure at the first posterior fixation and then anterior fixation with stabilization. And you can see this is the vertebral body under C-arm. And this is the patient 6 months post-operatively. And the follow-up, the cage sank in the bone, but the patient is still doing fine. And we have a third case here. We have a 63 years old female patient with a vague thoracic pain. A CT guided biopsy from a lesion in the thorax was performed. She has a chordoma, and the tumor board requested an Enbloc resection. This is the CT of the patient, and you can see a huge mediastinal lesion, which is arising from 4 vertebral bodies, that's T6, 7, 8, and 9. So, and this is the MRI of the same case, showing the big lesion and partially compressing on the heart. So, actually, I was challenged by the case, and I didn't know what to do, whether to perform the surgery or take the risk or not. So I took the X-rays, and there was a meeting in Wiesbaden, and I met Dr. Boom, and I presented him the case. And he gave me some tips for the surgery, which did help me a lot. And there was a big discussion regarding the method of the surgery. This is also an MRI of the heart, showing the lesion compressing on the heart. You can see the heart on here. So after I got back, I spoke with a colleague from the thoracic surgery about the case, and we agreed to perform the surgery in 2 sessions, one from posterior and one from anterior. So by this case, there were some challenges which we had to face. I searched in the literature for something similar. I couldn't find much. One thing which irritated me is the blood supply of the cord, because when you do such resection in one vertebral body, you are risking some blood supply loss to the cord. But what if you cut the blood supply over 4 levels for the spinal cord? Would it be a problem? This was one problem for me. And the other problem, which was raised from the thoracic surgeon, the heart. How would the heart react for the loss of pressure of the tumor when the tumor is once removed? And the other discussion, whether to perform the posterior surgery or anteroposterior surgery. At the end, we decided to perform anteroposterior surgery. This was the suggestion of the thoracic surgeon. And the last problem was the implant. we didn't have an implant which could bridge this distance. So we made our measurements. We had the CT, and kindly enough, the company Medicon, they come to us and we sat together and we made measurements of the implant we want to put in to replace the defect. It took like about 2 weeks to manufacture the implant as a custom-made implant because there was no implant in this size. And we started with the posterior surgery. Like Dr. Hesham always told us, first secure the field with a fixation. So the first thing we do is to insert the screws and insert one rod at least to prevent irritation of the cord through instability. And then we performed a laminectomy over the 4 levels. We performed a discectomy from both sides for the upper and lower discs. We removed the part of the ribs and part of the vertebra, part of the ribs and the transverse processes on the right side. On the left side, we performed it minimally in order not to disrupt the vascular supply from the left side. So we only removed the heads of the ribs and the transverse processes. We didn't remove much from the ribs. And we cut all the nerve roots on the right side because it was the must to remove this lesion with the part of the ribs which were affected. And then 1 week later, we performed the anterior surgery. This is a tumor. You can see it. This is the first image. And then here, after dissection and preparation of the vessels from the tumor. And this is the spinal cord from anteriorly. And if you look here, this is the aorta. Sorry, here's the aorta. And you have the lungs here, and you have, I think this was the heart. And we inserted the implant, which was extra manufactured for the case. Luckily enough, the implant was the right size, but only after we have distracted it for the maximum. And here is at the end of the operation, and you can see the implant was inserted from the right side, and you can see dorsal to the implant is the cord, and again, on the other side is the aorta. This is, okay, so sorry, this is the immediate postoperative X-ray. This is not 1 year postoperatively. This is the immediate postoperative X-ray, and you can see the pins from the tucker here. And this is X-ray 1 year postoperatively. And in order to assess the recurrence of the tumor, we performed recently a CT of this case showing no recurrence of the tumor. And this is the patient in our department, doing fine, and still have some pain and numbness on the thoracic side, on the right side, but she is happy with the end result and doing fine. Thank you for your attention. Thank you.
Thank you, Mansi. Very nice case presentation, especially the last one. It was very challenging case, Mansi. Actually, it was the last lecture in this webinar. I would like actually to thank all the presenters. I would actually also thank all the attendees. And the last thank and the last credit, I will give it to Professor Adel Rifat because of his genuine idea to collect our flying birds together through these webinars. Actually, it was his idea, and I think this idea is going very fine. I will give now the talk or the microphone to Professor Adil Rifat to end this webinar.
I think, Yasser, I did a mistake. I think every talk should be a symposium.
Yeah,
it is very rich. It is very rich. Every talk needs a symposium. And every subject is very special and very genuine and very challenging.
Yes, exactly.
I think I have many questions, but I think I am very happy with first with Dr. Hashash talking about minimally invasive spine surgery, which is a very big expanding field. And also Dr. Shosha talking about endoscopy or thoracoscopy assisted surgery. And I think I have an idea of doing, I'm not sure it will be working or not, to do a online like workshops for such techniques, new techniques. So our colleagues here should get some benefit of online workshops. Maybe, I'm not sure. And also the talk about Professor Saghier about gymnastics in Egypt. The parents are getting crazy about competition, and I think gymnasts who are achieving a medal or something in the Olympics, they have something genetics, so their spines are not normal. So stretching the spine of the normal people, like Professor Saghier said, usually put a lot of stresses, as he said, on cartilage and the bone and the bars. So I think in Egypt we should be a little bit quiet and less competitive with our pushing our children towards the abnormal zone. Which is, I think they are not normal. The people who are getting golden medals in gymnastics. At the end, Dr. Yasser, oh my God, I think the case of chordoma of the dorsal spine, it's very challenging, extremely challenging. But I think the key of success is you applied the system, not of anything, in resecting this tumor. You applied our system, which is called the concept of curative margin, where you use the ligaments, use the part of the pleura or part of surrounding fibrous tissue as a barrier. So this barrier is considered as a safety margin. This barrier theory is more explanation or more modification to the method of Enbloc. So if you joined us last week about the tumors, we talked too much about the surgical margins and the wide margin, because we are talking about the wide margin. And the definition of wide margin, we cannot measure in centimeters in some areas, like the hand, the foot, the spine. So we developed something called the barrier theory, where you can, for example, the posterior longitudinal ligament is a barrier. It gives you at about 2 centimeters. The intact pleura or a part of the pleura or a peritoneum, it gives you 2 centimeters. It's a single level. It is a one layer cell, but it gives you 2 centimeter margin. So I think this is the key of success, because chordoma after 1 year without local recurrence is a marvelous success. So yes.
I have to admit برضو ان الليفل بصراحه خدمني، يعني ان هو تبقى T6789 centralized in the thoracic spine، فدي برضو بتسهل الامور. يعني احنا يمكن في حاله كنت مرت علينا قبل كده، هو كان كردوم في cervical spine and it couldn't go nice because you couldn't do radical resection because of the vertebral artery. So it wasn't a success. Okay, but هنا في thoracic spine we have the chance يعني to remove it completely, and I think I have seen some cases also. I remember a case with Professor Saghier in Egypt where it was in sacrum. Where I assisted him, and it's a big surgery. But if you get it in block, then it makes a big difference, especially the cordum. I can remember the case with Professor Saghier from that time.
Why you didn't think about using a fibular graft?
لان انا فكرت ان اخد فيبرال جرافت واحطها posteriorly. I don't know if the fibrillar graft would survive all this load. That's such experience. Maybe it's loss of experience in this field.
Yeah.
Yes. Maybe it would have been better because of the fusion rate. Now we have a long distance covered only with metal.
But a very nice case. Very good job, Dr. Yasser. Thank you very much. So, do you have any other question, Dr. Yasser Alam? Is there any question from the audience?
دكتور محمود نفادي كان سائل سؤال ورافع ايده كان عايز يتكلم.
هو Mahmoud is asking about the last case. The question is directed to Dr. El Mansi. Mahmoud said the last case, double thoracotomy incision, was the thoracotomy through a single incision or double level thoracotomy? The question to you, Yasser El Mansi.
Was a double level thoracotomy, and I found it strange. But as I've said, in this case, the approach was performed from the thoracic surgeons, and they decided it is better for them to walk through a double thoracotomy incision. I was a bit worried about the case, but they meant, okay, this is something we do usually in cases where they resect a part of the lung or so. So I didn't say anything against.
Okay. I think that you have answered his question clearly. Professor Adel Rifat, this was the last question, only question. And you,
Sulaiman is asking a question. You open the question and the answers, Dr. Yasser?
Yes, I opened the question and the answers, and I found only this question. From the others, they were welcome notes, but this was only question from Mahmoud Nafadi.
Okay.
Should I close the session, sir?
Yes. Go ahead, yes. Thank you very much. Thank you very much.
Dear colleagues, dear professors, dear speakers, it was a very nice evening. شكرا لكم، شكرا جزيلا امتعتونا بالتوكس بتاعتكم، وشكرا للاتنديز ان كان عندهم صبر يسمعوا مثل هذه التوكس في هذا الوقت المتاخر. All the best to our colleagues in Germany. Be careful, stay at home, and be careful from coronavirus. نتمنى لكم كل التوفيق يا اخواتنا، ونشوفكم على خير ان شاء الله. تصبحوا على خير.
Thank you very much. تصبحوا على خير.
مع السلامة.
Thank you very much. Thank you.